Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Tonight's topic is co-designing a flourishing future to benefit all. My co-host and moderator of the chat, Dr. Dan McCarter, is out tonight. He's not feeling well. He's feeling a bit under the weather. Dr. Dan, we hope that you feel better soon, and I can't wait to have you back on again. Our guest tonight is Dr. Rick Botelho. Dr. Botelho, welcome to the show.
Thank you very much. Pleasure to be here.
You know, I appreciate you coming to join us here, doing our kickoff episode for 2022. 2021 was quite a ride. It's unfortunate that we're having to deal with this Omicron just shortly right after Thanksgiving, hearing about this Omicron. I myself, me and my family, we spent the last 10 days being ill, started with our youngest, and then slowly everyone in the house getting, the upper respiratory like symptoms. We tested COVID negative twice. But I think if anything, with this particular wave, although it's very contagious, we're not seeing all the pneumonias and the complications that we were seeing with the Delta over the summer. So that's hopeful. Gives me some hope, at least going into 2022.
Let's hope so.
So, Dr. Botelho, I would love to hear about your background. Where you trained, and especially with your experience with NHS and how that sort of shaped your career with where you are now today.
Well, I went to Nottingham Medical School in the early 70s. It was a brand new medical school, and it was innovative. And that's the reason why I went there. And so a lot of the training was really person-centered. I mean, if I look at all the professors I had, it was really about the care of the patient without regard to, you didn't have to even think about the cost of care. And so that gave me an amazing grounding on how healthcare should be delivered, which is basically the ethos of ChenMed. I've long been a fan of it because I think, the intro, I think, sort of encapsulates what healthcare should be. And so I finished my training, did my vocational training in general practice in England. I worked in a suburban and in a rural practice while I was there. And I was very attracted to rural practice because for lots of different reasons. But I came over to the States, and that was back in 81, 82. And I went into a rural residency training program and worked there for 3 years before there was a hospital financial crisis, and they decided to close down the rural residency tract. And it speaks to the inequities in rural areas because they get a raw deal in this country. There's very little support. Anyway, so I went to University of Buffalo, and then I went to the University of Rochester. I was there for over 25 years. I was part of the residency training program, ran a fellowship program for education and research. And I've now moved down to Charlotte, where I'm 4 houses down from my grandson, and yes, indeed, it's a real treat. And I'm now working just 3 days a week in an integrative care practice. And I also actually last year I did something. I actually got trained and took the boards in lifestyle medicine. So I love learning, and so it's something that's never left me. But I think the imprinting experience of being in the National Health Service, and even when I was going through working in the residency training program, I was very fortunate to be at the University of Rochester because it was George Engel was there. He taught the biopsychosocial model. And the residency training program was very progressive. It was all about keeping people out of the hospital. And when I was there, I used to do everything. I used to go in the hospital, do delivery, all that stuff. And I didn't get paid for admitting patients to the hospital. I didn't get any extra money. So my incentive was to keep them out, because if I admitted them, it was more work when I was doing 2 weeks of on-call work. So sometimes I would go up to the emergency room and I would see the patients there, and I would override the ED physician's orders and say, this patient can go home. We can look after this patient at home. So my experience in England was very much, I mean, it's really ironic because, in general practice in the UK, you used to do telephone calls to patients. You used to do home visits at the end of the day. And you come over here, and of course, they talk about hospital care at home, which is an oxymoron for me. So that just gives you a little bit of flavor of my different perspectives. But what I think it speaks to is the profound influence that you can have at the beginning of your career that can set you off in a much better trajectory. My concern is that the system is so transactional, so RVU based. It's all about number crunching. These hospital systems regrettably have not woken up and seen the light of day, with things like direct primary care models. And it's antiquated and it needs to be disruptive. And I'm glad that ChenMed is one of many companies that's chipping away at a legacy system that is long overdue to be extinct.
Oh, gosh, hopefully more sooner than later, because healthcare healthcare transformation really, it equals, for me, it equals health equity. Because what we're seeing right now is the exact opposite of that. It's such a mess. It's a mess of a mix of systems. I don't think you have anything. Probably the closest thing we have here in the United States to the NHS, where the doctors are employed by the government, the patients don't see a bill, would probably be the VA. Outside of that, it's just such a mixture. I mean, if you don't have health insurance, it could very well you could very well feel like the way many people do in third world countries, where there's no system at all in place. You just the entire brunt of the cost is on you, unless you're sick enough that you need to be admitted to, of course, to through the emergency room. Then the hospitals will admit you. At least they'll have that. But the system it's very complicated. It's very, very complicated. So tonight's episode is titled "Co-Designing a Flourishing Future for All." And if I remember correctly, this past year we networked and connected with a lot of people. And I want to say that you and I first connected on Clubhouse. I'm not exactly sure, but I think that that's where we connected. And that's where I first started learning about the Equity Muse. If you could tell me a little bit about that journey.
Well, it's very interesting because what happened at the very beginning of the COVID crisis, I was just doing a locums job and I could read the writing on the wall because patient volume plummeted. I mean, within a week, it went down to nothing. And so, because I was doing a locum, I got basically 1 day's notice that I didn't need to work the following day.
Oh my
So,
goodness.
well, it was a blessing. It was a blessing because it gave me, I've been in academia and I've had the fortune of having sabbaticals. So I just took it as an unemployment sabbatical. The the long and short of it was it took me out of the eye of the storm of the COVID crisis and looked at it from a sort of zoomed out and looked at the big picture. And I decided to coin this phrase, equity muse. And equity, unfortunately, has multiple meanings. And depending on whether you're talking to business people or health people, it's got at least three different meanings. There's the business meaning of it, there's the legal meaning of, and then there's the health and educational aspects of it, or the social aspects of equity. So it's a confusing term, but the idea of a muse is a change agent, a particular type of change agent. And the purpose of change agents are to ask the right questions that inspire people to take effective action. So it's the power of questioning. And, I've put a link in there. Actually, I wrote a blog post. I did my inaugural newsletter, and I'm on my third weekly one. And the one that that I shared in the comments section here is basically looking at how we need to launch Equity Moonshot. And what Equity Moonshot is basically it's reframing exactly what the title of this session is, which is how do we co-create an equitable, regenerative, and sustainable future. And I want to be very clear, it's in that order, because the problem with the COVID crisis, as you know, is that it just exploded awareness about inequities, lots of different inequities. It did such a good job of it that, we should take it as a learning opportunity. But I'm not optimistic that we're going to be able to do that good of a job of it.